Hi everyone, my name is Madeline Souza. I'm the National Sales Director here at Hermes Medical Solutions Canada. On behalf of our company, I would like to thank everyone for attending this webinar via the CNM. Today's topic is all about the power of using the right software to handle the future of nuclear medicine. There will be 3 learning objectives. First, I will start by explaining the value and the benefits of a single vendor neutral platform in nuclear medicine practice. Secondly, our clinical director, Frédéric Fontaine, will demonstrate our latest tools with also the latest data from the latest whole body PET CT scanners in the market. And finally, our medical science liaison, Andrew Prideaux, will demonstrate our dosimetry tools and the CERT workflow. So what are exactly the value and the benefits of having a single vendor neutral platform in nuclear medicine practice? There are several. First, it is a smoother workflow. You literally consolidate all of your legacy scanner software and eliminate unnecessary workflow disruptions by using one single viewing and processing platform. By doing this, you also increase the speed of your workflow. It is a very user-friendly interface, and we work in close collaboration with our customers to understand what tools makes your day efficient. Also, it makes a big difference in connectivity. It is Hermes' strength to be able to connect users together, connect physicians with technologists, connect physicians with other physicians in other hospitals, and also connect from home to work. It is also the freedom of choosing whatever scanner you want. It doesn't make any difference because you're vendor neutral. So we can connect to any scanner platform, and you can select whatever scanner fits the needs of your department by simply adding some extra software to your platform. It is also a big difference with theranostics. We include several tools for dosimetry, such as voxel dosimetry, quantitative SPECT reconstruction, and organ dosimetry and CERT treatment planning and verification. Finally, the difference is also in our experts. Since 1976, Hermes has been supporting our customers across Canada. Most of our application specialists were trained as nuclear medicine technologists, and our platform to answer customers' calls is extremely fast. We make a big difference across Canada. Only in Quebec hospitals, we are implemented in 80% of the departments. The CHEM Montréal is our biggest and largest installation with 30 workstations. We also have major sites in Ontario and other provinces, such as University of Ottawa Heart Institute in Ontario, the Ottawa Hospital, the Civic and the General in Ontario, Niagara Health, Ontario, South Lake Regional Hospital in Ontario, Hamilton Health Sciences, UHN, Alberta Health Services, Eastern Health, BC Cancer. I will now pass the floor to Frédéric Fontaine, our clinical director, to demonstrate our latest tools. Enjoy.
Hi, everybody. My name is Frédéric Fontaine. I'm the Clinical Sales Director North America for Hermes Medical Solutions, and I'm a product specialist for our multimodality viewer. Our viewer is an advanced vendor-neutral software, and this presentation will highlight key features using recent studies from the most advanced nuclear medicine cameras on the market, hence demonstrating the benefits of our powerful software in your clinical environment. Now let's have a look at a dynamic PET CT from the Siemens Quadra. This data set is huge. It is 15 gigabytes. This is immense for nuclear medicine. This particular PET here has 62 time points of 645 slices each, so about 40,000 files just for one PET scan. And our multimodality viewer can handle that type of data, contrary to what you might hear from different camera vendors. So you can see here the CT. Now let's switch it to a bone window level. So here I can use a keyboard shortcut that can be pre-configured to whatever value you like. I displayed these into this particular type of layout. Again, I have a workflow where I can choose and build customize layouts. And I chose here to display it first in this TCS 3D display. So I can scroll through, obviously. I can look at the MIP. But here, to make it more interesting, let's go full screen on the MIP. And let's activate the dynamic PET. So as soon as I hit the little play button here, you can see it's going through the 62 different time frames, and you see the corresponding time right beside. And you see that it goes through the different time points nicely. And it's a MIP, so we can add a rotation element to it. And it keeps going through the time points as well as it rotates through. So a display like this uh, looks pretty standard in the sense that you're used to seeing PET and CT fused together. But in a MIP like this with a 15 gigabytes data set, it's a it's a big challenge to build a software that can handle this, and our multimodality viewer is powerful enough to handle these big data sets. But it is a dynamic PET, so let's go to a nice display here where I can use the data tree to drag and drop whichever data set I want onto my display, which is a nice feature as well. If you ever build a workflow and you're looking at an exam that does not fit your regular string matching and it's not displayed properly, you can always drag and drop data sets from the data tree onto the display. So here we're looking at the PET dynamic going to different time points. So here I will pause it. And let's make some volume of interest so we can have a look at what's happening over time. So here we could do an ellipsoid, for example. So here you have all the different icons to create volumes of interest very easily. So ellipsoid, I can simply click and drag, and now I have a volume of interest. And it's calculating the statistics. And afterwards, let's do a single click segmentation. So this way to create volume of interest is based on a SUV threshold. Everything that fits the threshold is highlighted. So here, let's select the bladder and let's make a volume of interest. So one click with a specific threshold and it creates a nice volume of interest. As you can see, if I scroll to different slices, it creates a nice volume, and you can see it 3D rendered on the MIP as well. So you see how quickly it calculated the values. This value is for the frame, the time frame that I'm currently on. So if I hit the play button here, it will now go through the different time points again. And as we're going through the time points, you see the values change in the table here live. So we're talking about, again, a 15 gigabytes data set quantified live, which is pretty awesome. Now let's go into graph mode. Same thing. Here we're looking at mean SUV. We can go to SUV max, for example. And now the SUV max within the volume of interest are shown here in the graph. Obviously, whenever I hit pause, I can see my values. I could say screen captures of this. I can do whatever I want at this point. And obviously, this is a dynamic PET. So the most interesting portion would be the time activity curve. So this little icon at the bottom here. I click on it, and now I have my nice time activity curve. And as you can see, as it is cycling through the different time points, there's a little star here that keeps moving along the time activity curve. So this is the frame that I'm on currently. If I pause this, I can also use the graph to do a time triangulation. So if I click on any of those time points, it will go to the image that corresponds to it, which is great. And again, I can play this back and look at its cycle and still have my time activity curve. If I take the volume and I move it around somewhere else, as you can see, it recalculated the time activity curve on the fly. Again, quite powerful. Here I hit pause. I will go back to my statistics table, and what I can do for the frame, if I hit this little plus button, I can also have obviously all the statistics for all the time frames, the reference time, the frame duration, and all the stats are available here. Those statistics can be exported as a TSV file if you're doing research or if you're interested in doing some other graphs with these statistics. You can copy paste as well any of these field or all of them and directly paste them into an Excel spreadsheet. So again, in conclusion, our multimodality viewer can handle really big data set and keep all of its functionality, and it's even able to do a lot of calculations very quickly and live. And this is a beautiful case, as you can see. This next study is a dynamic SPECT from the Spectrum Dynamic Veriton camera. So the study itself is not as big as the Quadra, so it's not as difficult to handle size-wise, but it is still a challenge to make it compatible with our system because dynamic spect, and especially the Veriton, is very new to the market, and as a vendor neutral company, when a new camera comes to market, we have to find data set and make sure that we can display them. And when they use brand new technology in their own DICOM flavor, then it can be a challenge. But we find a way to do it, and so we continue to be a great vendor neutral software company that can handle any type of data sets, just like this one. So you can see it here. It's going through the 85 different time frame, and here if I create a volume of interest, again, we can see the statistics being calculated live for each time frame. You can obviously look at the time activity curve. Same thing, we see the evolution here through time with the following the little star. And we can use graph mode, and all the statistics for all the frames again can be exported. But really here it's a nice data set to show, first of all, what can be done now with SPECT, which is impressive in itself, but the adaptability of our software to become quickly compatible with brand new technology available on the market. This patient is a high resolution PET-CT coming from the United Imaging Total Body Scan, the U Explorer. So again, technology that is quite recent. We were able to add it to our portfolio of data that can be open and handled by our multimodality viewer, as you can see here. Again, we're looking at a different layout than before. So layouts, as usual, with any Hermes configuration, can be customized to your liking as part of any workflows. So in this case here, we're looking at fused TCS, just PET and MIP. And again, the overlay as well can be customized. As you can see here, part of the overlay that can be interacted with. For example, the fusion percentage, we can simply scroll the wheel of the mouse and change our fusion percentage. And I will show you the different steps and slabs in a few minutes. So here, what is very interesting on top of being able to show you very high quality images is the MIP itself is beautiful. If I go full screen here and I zoom even more, so again, I can use keyboard shortcuts, in this case, Control and left mouse click, and I can zoom. Here, I can zoom even more to really show you the high quality. There's no pixelization, there's no line, there's no diamond shape artifact that is very typical of a trilinear interpolation, which is what you would find in most viewers. We've gone a different way. We've gone completely 3D with a tricubic interpolation, which is why you don't see any artifacts and why you see this amazing quality for the MIP. Our viewer is also a full 3D viewer, which means that you're never looking at a 2D image. You're always looking at a 3D rendering of the study. So again, if I use this cube in the bottom right, I can change the angle and I can look whichever way I want at my image. To show you what the interpolation does, if I zoom even more here and I remove the interpolation, this is the raw image. This is what we get from the vendors, from the acquisition station. So it is looks quite pixelated. But with our tricubic interpolation, then it becomes this nice, crisp, very, very smooth image. And that is how we can create, superior image quality versus other viewers using the same data set. If I go to a different TCS display here, and I drag and drop my CT and my PET to the image. So here again, it looks like we're looking at 2D images because we're looking at slices, but really it's a true 3D representation of the data set. We have a plane basically cutting through a 3D image. So the best way to show you that is indeed a 3D image is again the ability to reorient the patient data set into any plane that we want, in this case using the rotation cube. So again, the interpolation is recalculated every time we change the orientation, so that even if I'm not in the traditional orthogonal plane, and if I zoom in, I'm not losing any quality on my image. It is always a proper, tricubic interpolation and giving us the maximum quality for viewing this image. Same thing, this allows me to go into slab mode, and I can decide to look at my study not just slice by slice like it is by default, but I could say show me slabs of 10 millimeters, and now you can see that every time I'm looking at this study here, the coronal view, and I scroll through, I'm scrolling through 10 millimeters. And again, the quality is perfect. And again, here we're looking at mean. We could change that to a maximum intensity projection, or we could switch it to a minimum intensity projection, which you've seen the change here at the bottom. I go back to mean. We're looking at the same 10 millimeter, but the effect is different. But this is only possible because we have a true 3D viewer, and this is how we get this high quality rendering for our images. This case is a PET CT from Canon. So again, a brand new camera to the market, which we can obviously display in our multimodality viewer. Here we have an actual workflow that was built for this particular case. So instead of having my default workflow, I've named this workflow 1 PET plus 1 CT ACE, which is their CT reconstruction. And I only have these three layouts, which is how I decided to build this particular workflow. So I have my default layout, which will come up right away with the data sets displayed. And then I can switch to any other layout that I want. So here again, I've built the one with only transverse view and the MIP. So fully customizable, like I mentioned before. It's just a matter of telling us what you want in the workflow, and that's it. So this case is a PSMA case. If I go back here, again, I can use this case to show you again the single-click segmentation. If I click on it, I can choose SUV threshold. As you can see, I can use my preset, but I can scroll up with the wheel of the mouse to any value that I want. And the effect is reflected on the image as I scroll through the values. So if I stop here at an SUV of 10, and I'll just create volumes for the salivary glands. So here in a few seconds, I created 4 different volumes. If I want to see the statistics of those volumes and I don't have in this particular workflow a layout with the stats box, I can simply hover above the regions that I've created and it will give me my values overlaid on the image. I can do that for each of them. If I right click on any of those regions, I have a lot of options that I can do. I can change the color. I can, invert the region position. I can duplicate it. I can get from a region, I can use that region as a reference and calculate a smaller region for the metabolic peak or the MTV. I can split that region to smaller volumes. I could use that region as a reference for SUVR. Delete it, rename it, and of course I can export it as a DICOM segmentation to keep it for future comparison. Those are my options. Obviously, there are many ways to create volumes of interest, like the ellipsoid. We can do a 2D ellipse as well. We can do a new paintbrush, so that would be a manual mode where you can manually draw a region and then skip over a few slices and then draw again. And the software will interpolate between the regions that I've drawn. So as you can see, it does a very nice job to do the interpolation. Since we're looking at different tools, let's look at measurements. So you can do a measurement and then let go of the button and it goes away. Or if you want to keep that measurement, then you can simply click and click again. And then as part of the annotation list, you will see your measurement. You can do annotations as well. Test. You can use the corner to point an arrow. And again, they're present in the annotation list so that if further along your review, you're scrolling through and then you want to go back to where you drew the measurement, you can simply double click and it will triangulate back to that slice. Same thing for the segments. You can always double click and it will go back to the different volume of interest that you've drawn. So lots of tools available, and just a nice example of a workflow that is created to certain specification, showing the versatility of the software. This case is a Ultra HD whole body PET, and it's a great case to highlight a nice feature of the multimodality viewer. It's the ability to create a threshold and identify every lesion in the body based off that threshold. So again, we can create presets if there are values that you use most commonly. And if not, you can always change the value on the fly. But here with only one click, now I've created a full body volume. If I hover above, then I get the size, the SUV max, mean, and the total lesion volume and SUV values, so total lesion glycolysis in this case, for the entire study. Of course, in here there are not just lesions, there are a few normal organs. So brings me to this next tool, the blob splitter. So all I have to do is click a specific volume and I can remove it from the full volume. So here in only a few clicks, I was able to remove my normal organs. And I'm left with a remainder volume. And again, I have size, SUV max, mean, and total. I can go one step further if I right click on this remainder at this split option. So I can say I'm only interested in volumes that are above 5 mil. And here it keeps the biggest 25 regions are now highlighted, and it keeps the rest as part of a remainder, which I could split again if I wanted to, if I wanted a full list of all the lesions. So here, as you can see, it did that within 1 second, so it's very, again, very fast. The computation capabilities of the multimodality viewer is great. And now if I hover above any of those regions, then I can get the values for each individual lesion. Again, if I double click, it will triangulate to that lesion, and I could select all of those and export them as a DICOM segmentation. So this is a great example of a case where you don't want to manually identify each and every lesion, so you can use the threshold tool to identify everything and then remove what you don't want and split the full volume into smaller individual lesions afterwards if you decide to. This study is a great example of lesion tracking through time. So here we have 4 time points and we'll be able to do SUV comparison. This is a lutetium-177 PSMA study. So 4 different time points, looking at coronal and MIP for each of the time points. These time points were co-registered on the fly when I loaded this study. It takes about less than 5 seconds to register all 4 time points. And our registration algorithm is very fast and very good, which makes it very easy to do comparison through time. This is a SPECT CT. We're not looking at the CT portion here, but the SPECT CT reconstruction was done using our own hybrid recon reconstruction. And because we calibrated that camera for lutetium, we're now able to get SUV values present here in the study and get values to be able to compare 2 different time points and scale the study properly as well. So let's identify some lesions. So again, we'll try to do it via the single click segmentation. So we're using an SUV threshold, the same one for all 4 time points. So I'll have to scroll through, find my lesion, 1 click, then I get my first lesion identified here. I can go straight to the second time point with 1 click to activate it, and then 1 click to create a lesion volume. And I can repeat the process the different time points. And now I have all my segments here. So I have one lesion in the 4 time points and a smaller one in 3 out of the 4. I have all my statistics here available at the bottom for each of those segments. I could rename them if I wanted to. And if I go to column charts, that's where it becomes interesting. So right away, because I've identified more than one lesion in each of the time points, except the first one, but still it sees it as 4 different time points with multiple lesions, it goes into comparison mode. And this mode, the software will use some AI to identify each lesion, its position, its size, and compare it to different time points and associate them together. So we can see here the dates at the bottom, so the 4 time points here. So the lesion that is part of the 4 different studies is first here on the left. If we go to SUV max, for example, then we'll see that the SUV max for that lesion has been identified, and there's a percentage of evolution through the different time points. But the software knows that these 4 lesions go together, and then these 3 lesions go together. And that is achieved with the AI program that we've integrated into the multimodality viewer. So that's great. We can get a nice comparison. We can do it for multiple values, even the volume. If we go to size, now we're looking at volumes of the different lesions and the evolution over time. Again, you can create screen captures of this. You can make a nice display where you have up and down or left and right, the graph and the statistics, and you can export those as well to Excel. But it makes a nice and easy comparison tool. Registration is done very quickly. Creating volumes of interest is very easy. And then you have the graph in comparison mode that makes your life even easier when you're trying to compare the lesions together. And let's not forget that we have all these nice SUV values because of the SUV spec reconstruction. So now I'm done with this case. If I want, I can save a nice screen capture of the entire screen. It's now added to my data tree, and I can save that to a USB stick, or I can export it to your main archive. And that's it for this case.
Hello, my name is Dr. Andrew R. Preto. I'm the medical science liaison for Hermes Medical Solutions, as well as being one of our dosimetry experts. In recent years, the last 8, Hermes has added multiple products to our dosimetry portfolio, and we've gotten to the point where you may be asking yourself which one is right for my application. I'd like to take you through a few of our products and when they are the best for your situation. One of the first products that we'll talk about today in our dosimetry library is our organ dosimetry. And organ dosimetry is a way of taking patient imaging, whether it be all planar, all SPECT or all PET, or a combination of one SPECT and planars, to generate a normalized cumulative activity and feed Olinda exactly what it needs to run and generate mean organ doses. So we would take our patient's imaging like we have here, and again, this will represent the combination of planar and SPECT. I've drawn my volumes of interest already for the sake of time. I've also made sure that our alignment between the SPECT pseudoplanar, where we flattened out the SPECT image as we have it, and the program automatically finds the whole body anterior image that's closest in time to the SPECT, are fairly well lined up. It will attempt to do that on its own, but if you have to adjust it, you can. And now it's up to you to draw the regions of interest on the planar So the first thing, I do have a standard, and I'm going to generously draw the standard here with the attempt of being able to move that around as it did move between different acquisitions on this patient. Then I've got the liver defined in SPECT, so I should probably do so in planar as well. And while you can draw all these in on each time point, it's very well represented all on the same time point here. So I'll be drawing them all here. Uh, that is not a limitation. It just works quite well here. To do so, left and right kidneys defined, the liver is defined, and the last one that is already drawn is the spleen. So as soon as I find that, we'll draw that. There's the spleen. We can now copy this over to all regions. Anteriors will be flipped from posteriors and we'll end up here. Now it's possible to move these around. I can move all ROIs, or I can move individual ones. And you'll notice that I'm moving here in the posterior. The anterior will catch up to it, but the other time points will stay where they were. So we know that this is a uh, fixed two-headed camera that this came from. So the expectation is that it will be mirrored in anterior and posterior. Let me just clean this up a little bit more and we'll move right along. So once all the organs seem to be highlighted or circled, drawn for regions, we can close this. We can go to our curve fit setting. We would actually, of course, make sure that we're dealing with the right amount. I think this is a 4-hour delay, so we'll move the time, which it was unable to read from the header due to the high amounts of anonymization. We'll pick the most appropriate phantom. In this case, it is an adult male. And we can continue. Again, there are other options that which we can discuss later, but for the purposes of an overview, we want to do a curve fit to all of these just to make sure that we're both getting the long-term behavior correct, which is usually best evaluated toward the end, as well as the early behavior when there's a saturation, and get all of that. Once we've got good fits on everything, it has now generated for us a normalized cumulative activity. We feed all of the work we've done into Olinda, which pops back results for us. And we end up with a screen capture of what our regions look like, what our uptake curves look like on a log plot. We've got the uptakes, the fitting parameters, and the normalized cumulative activity or residence time. And then, of course, the doses. Alpha, beta, gamma contributions, the total, the equivalent dose, and the effective dose. Likewise, the inputs that got us there. These are all saved back as an Olinda save file, as comma separated values for all the numeric parts, and as PNGs for all the imaging parts, serving as a report for your patient. Again, this serves as a great way to get statistical data for what a phantom model of the human would experience given these inputs, and we can apply it to our patient, though largely statistical, still a lot of information to be gleaned, and good dosimetry per patient, matching at least what the average person would be. So if we've got planar data or planar and only a single SPECT, this might be your best patient modeling that you can do given our product. Until you get to having multiple SPECT or a single SPECT in single time point, the next product that we'll discuss. Now we come to the Hermia voxel dosimetry, a standalone product that actually will allow a user to do truly personalized dosimetry and allow it to be done on a workflow that fits clinically to the point where you could do it for every single patient that comes in for treatment. Let me prove that to you. So the first thing that we're going to do, and remember, we are now given all of the data at the end, but in truth, these trickle in piecemeal at a time and could be done to where you registered many of these data sets before you even got in and make it a small amount of work each day instead of a 5 minute job all at once. But let's do it as if it was all at once. Worst case scenario, we get a choice of which reference study we'd like to use as our CT that we're going to make our patient's anatomy later. And if we had one that was a high dose CT and the rest were dose sparing, certainly we'd pick the one that was the high dose CT. In this case, they all are, and so I'll pick one as it's easy to remember which one I've selected. We'll continue. And it's at this point we'll be given a display that tells us both what we've loaded for SPECT or PET, in this case SPECT, and for CTs. This is a lutetium dotatate patient. And we have a full registration possible, but for the sake of time and the fact that I'm not going to actually do any patient decisions based on this, I'm just going to do a very quick registration manually, but all of those sins will be forgiven because we'll do a deformable registration from that initial starting point, which is actually pretty good. Deformable registration, however, will make it a little bit better. So we'll see everything pop into really good registration as soon as this is finished. And it's probably worth noting that at this point, and as I continue on until I make a statement changing your mind, that we don't have to know anything about anatomy. We don't have to know anything about where the tumor is or anything in order to calculate, clear up until we calculate a dose here. Let me do an alignment again for now the third time point registered to the first time point. We've already done the second, and I over moved it there. Let's get at least close, and then again we'll let the deformable registration do its work. But by not knowing, not having to know what every organ is beforehand, this becomes no more of a taxing problem than SPECT reconstruction, and something we feel like could be a step for the technologist to do. And then at the end, once we've got a good dose map that we're going to generate, then we'd call in the physicist or the physician to segment out what's important. I'll do one last deformable registration, and in a few seconds we'll have 4 well-aligned SPECT CTs. Eagle-eyed among you may notice that there is a VOI option, and in this next version coming out, it would actually be possible to do a whole organ clearance rate, and so you could define the liver or the spleen or whatever and get that clearance rate. However, as I said before, if we're looking for something that's a clinically workable workflow where the technologist isn't spending any extra time, or you don't have to be a super tech in order to do it, we'll stick with this. So we'll extrapolate the uptake phase before our first image with physical decay, or we could do it linearly. I'll do physical decay. And a mono exponential fit from the last 2 time points to go past where our imaging takes us, though after the last time point. And now we can just calculate this. And we have our results. So it would be possible now to do well, first off, let me show you that not only do we have a per voxel Hounsfeld unit from the CT, not hard to do, we also have our amount of gray that was given per voxel. So once the calculation is finished, which only took a few minutes, we find ourselves here where we could save a dose map that we would be able to review later or by someone more qualified to do it. Or we could, if we were the person that was qualified, we could launch the viewer right away. So save dose map or launch viewer. And the product that will come up looks a lot like this. We have our dose map. So every voxel here is dose. Let's find this big area here with a lot of a dose, and we'll just do a quick segmentation based on that. And we can see that we get the size in milliliters, minimum and maximum pixel value, as well as the mean and the standard deviation. That is also something we can DVH. So we've got a dose volume histogram. And as you can see, this received a very significant dose from this lutetium. But of course, it being the target, that's probably a good thing. And we're not limited to just targets with uptake. We could take something from anatomy. We could do, say, our liver, and we could segment that out. Let's use a slightly smaller brush. We'll go to the bottom here. I'll be a little heavy-handed for the sake of speed, but you can see that we could certainly do that. And then as I think about it, it might be easier to do this on a large screen. And we could certainly take advantage of our auto feature to subtract out areas that we were a little heavy-handed or on, and maybe we didn't quite get out to the edge here. But I've also drawn all the regions that in between. And if any of them are wrong, I can just come in and touch them up. So not only will I fix this slice, but it will now help with all the other slices that we've drawn on. So we can quickly get to a fairly decent volume. Let me do a little bit more liver fairly quickly here. Again, I could spend a little more time being precise, but in the interest of hurrying it along, let's just do something like this. Now we've got a normal organ, liver, and like before, we can see its dose volume histogram. We could also see its mean, max, min, standard deviation, and size. So the ability to completely analyze anything can be done after the fact, and the saved file serves as the processing step prior to physician review. That's our voxel dosimetry. The best fit for this would be patient-specific evaluation of a dosimetric process. Likewise, the voxel dosimetry is capable of calculating a dose for a single separate therapy than it is for image. Currently, this is only CE and Canadian marked, but we'll be working on FDA approval shortly. But that gives us the ability to handle many isotopes like technetium-99 MAA as a surrogate for Y90 or gallium or. So the ability to do this is quite powerful. There's also a single time point method available for physical decay, effective half-life total, or in fact a Hanscheid approximation for lutetium dotatate. That is voxel dosimetry. The final one of the Hermes dosimetry products that we're going to cover during this session is our CERT program. This is for calculating both planning and verification of MAA as a surrogate for either the resin or glass spheres, whichever one you're using, and calculating an expectation of what to deliver safely. Here I do have available to me a diagnostic CT, but I also have the spec CT, and that's all I'll use in this case in order to do that. The easiest and first thing I'll do just to get started is we'll grab the CT, We'll do a segmentation and we'll look for lung, and that will let us draw a volume around the lung quite easily. Now, it might not be quite as easy to do the liver, but we'll knock it out either way. I'm going to go ahead and make the screen full size for the sake of ease here. And it looks like that's the very first piece of liver. I'm going to make my tool brush just a little bit bigger. And we won't get the aorta in there. And we'll try and draw the very first slice of liver, possibly poorly. Then I'm going to come down quite a few slices and draw again. And again, I'm mostly worried about the edge, but if I don't do a great job, let's not include too much cardiac there. We can certainly come back to anything and touch it up. So we can come back in and add. Likewise, if we start outside, maybe I got a little too much cardiac here, we could delete what I shouldn't have, and actually probably here too. So we now have another good slice, but we've also interpolated everywhere between. And any slice that we don't think has met our high standards, we can just come in and touch up. But this is a demo, so I may not be that careful from here on. Let's just get the rest of the liver. And at this point, we're fine with including the diseased portion of the liver, the perfused liver. This is our total liver, so we'll be including all of it, or trying to include all of it, depending on how good a job I do. We come down here, and I'll clean that up momentarily. We'll get back into here a little better. And there a little better. Certainly try and clean that selection up. Finally down to the end, and again, you've seen the versatility of this tool. You could certainly clean up anything that you didn't do a great job on in order to get a nice anatomical volume for your liver. And once defined, I might also be interested, let's label that as what it is. This is total liver. And I might be interested in only perfusing, maybe say this lobe. So we could go back and also do that. We could have here a brush, and we're just gonna define that. And I might even be a little sloppy and go outside of it, because I have a way forward there. So we'll do a little bit more. And we could restrict this liver to have to be inside of what we already called total liver. So let me relabel this as perfused liver. And then because I was sloppy, we'll restrict it to being inside of the total liver. And now it won't exceed our boundaries like it did before, which is nice. It means we can paint a little bit less carefully. And then if we make the spec, I'm going to be lazy. Let's go back to the full version. Oh, and we can call that segment 1 lung. But we can actually define our lesions completely by their uptake. So we'll find the hot spots here. It tells us where they are by preview and which ones are separated. They're glowing red until I click on them. That means they're not ones that have been selected yet, but meet my criteria of being 50% or hotter, which is a criteria we could set differently. And of course, this is my one that I'm most interested in. So once I've defined all those, and all the ones labeled segment will be tumor, now we're ready to fill this in. So I'm going to say that either right now my lungs region anatomically is the one I defined as lung. My total liver is the one I defined as total liver. And already I'm calculating my lung-liver ratio from 3D. I'm also calculating my sizes for everything. I can do my perfused liver, which of course is the one that I drew and called perfused liver. And now the difference between those is my healthy liver. Um, Likewise, we can subtract out our target lesions. And like I said, everything labeled segment is one. You can keep adding them, so there's no theoretical upper limit to how many lesions you feel like tracking or defining. And you'll notice that all of these, I could have an activity volume that is different from my physical volume. That'd be if the patient's breathing had led to a different uptake or whatever. But all these tumors now have been subtracted out of the healthy liver, out of the perfused liver. We're left with perfused healthy liver and healthy liver. And the only thing we're missing is to up the dose. So let's take a look at what dose does my healthy liver either reach, oops, got to stay on going the right direction. My healthy liver could reach 40. My perfused healthy liver reached 80. That's probably not one thing we want to do, so we could calculate that down to where that reached 40. And of course, we'd also want to check our lung, which is 2.3, so we're well within our safety margin there. But these calculations can now all be saved to a report. And we'll just click this in one go. It's done. And we're ready to go order 1 gigabecquerel of therapy for this patient. Now it's a few, however long it takes you later. Not only do we have the original images from before, but we also now have our PET CT from the actual administration. I'm going to launch the program again, including the PDF, and so I've now got the PDF that we had from before, our prior study, as well as our PET CT. This is the planning phase, but I'm now interested in the verification. And because my label matching didn't work, I can populate these myself, so I don't have to wait on everything else. As you can see, it's attempted to bring the regions in from the prior study, and it's done so. Let's change the SUV scaling to something a little bit more reasonable. We'll do this, but we'll set it to full dynamic range, so that we see something a little more tolerable. And as you can see, all of the regions from before were brought in, they're placed on the PET, and we're evaluating the difference between the planned dose and the therapy dose, and the difference between those. Automatically done. So other than pre-populating the image area, which could be done with better label matching, we get our final answer. And again, this could be made into another report for entering into this patient's therapy, but you've not only done your planning, you've done your administration and your verification and the difference between planning and therapy. So that's it. I thank you guys for your attention.